Stephanie, I know we talked a little bit before, but still, can you introduce yourself a little bit?
Yeah, absolutely. So I'm Stephanie Cohen. I'm an assistant professor in biomedical engineering at the University of Delaware, and I run the Orthopedic Tissue Mechanics Lab there. And a lot of my background is in soft tissue, musculoskeletal soft tissue, so ACLs, Achilles tendons, patellar tendons, looking at how their actual structure and function change either in healthy occasions or after injuries.
Nice, nice. So, I think in the past few years, like we've been talking a lot about the injury mechanism. What about the tissue itself? Like, there's some debate about mm, healthy tendon can also rupture for an athlete, but also like there's also research saying like all those rupture they had uh they have like at least for Achilles tendon, they have plantar fasciitis. They have some sort of like Achilles tendon pain prior to the tear. So before we like talk about like rehab, what are your thoughts on like this topic?
Yeah, so definitely is a big topic right now, right? And especially, I mentioned I do a lot of structure work, so a lot of the medical imaging, so whether that's ultrasound, MRI, CT scans for some other tissues, there are a lot of questions about whether we can predict if a tissue is headed down a bad road before it hits a catastrophic failure event. Um, and I mean, I think the jury is still out to some degree. I think what it seems like is happening in the research field right now is people are realizing that there are multiple ways to tear an Achilles tendon or an ACL or whatever else. Um, and it certainly does seem like there may be some buildup over time of damage. Maybe there's some extra inflammation in the joint from the mechanics end. That certainly could change kind of how the tendon actually responds to stretch. So it's possible that if you've got an inflamed tendon when it's moving through what would normally be a normal, healthy range of motion, maybe all of a sudden that does actually cause some problems and some kind of abnormal stress uh, locations. Um, so I think that's also a really key question because if we want to get to where we can predict injury, we need to know what these markers are. So, not only does it matter if the tendon is perfectly healthy going into the day, but are there actual flags that we could check in on? Is it high water retention? Is it actual like micro damage to the tissue? Um, I don't think there's a definitive answer right now, but it certainly seems like, at least in some cases, that rupture isn't out of the blue. It actually is coming in when you already have something a little bit abnormal going on, either in the tendon or in neighboring tissues.
So talk to me about like what are some markers or some flags we can like at least track before things could like go really bad.
Yeah, so I think, especially in the Achilles tendon, we're thinking a lot about things that could look like Achilles tendinopathy, maybe Achilles tendinopathy, and whether that actually leads to rupture, or if those are two totally different roads that people are going down. Certainly, if you have Achilles tendinopathy, that's generally diagnosed off of symptoms. So that's a very painful, localized area of the tendon that's having issues. Honestly, people who have really painful tendons don't tend to push them to the point of rupture. So it's kind of a built-in safeguard there. If your tendon hurts really badly to move, you're probably not going to do something that ruptures it. Um, what we might be starting to look at and what there's some active research going on into is the actual matrix getting disorganized in a similar way if you're going towards tendinopathy or if you're getting kind of that partial damage that could lead up to a full rupture. So thinking about, are there some key markers that we could look at with ultrasound of disorganization of the collagen fibers, neovascularization, where you're bringing in, the body is sending in a lot of new fluids and kind of, building materials, basically showing a lot of remodeling. Could we actually use that as a marker for, we might want to put up kind of a yellow flag here and see if, we need to check into things or make sure that someone's even just getting fully warmed up and actually prepared for movement at a competitive level.
So outside of imaging, like as a strength coach, because
Mhm.
as a performance coach, like I'm not a medical staff, so outside of imaging, is there anything else like we can track or like assess?
Yeah, so I think, I mean, key things that I would be looking at in terms of what you can assess or measure without any fancy equipment is being aware of what positions people are typically injured in. So if we're thinking about an Achilles injury, we're usually thinking about a big step back mechanism where they're getting, their foot out behind them very suddenly, very high force, and then the Achilles goes bad. Um, I would say if you've got someone who's more hesitant or if there's, they're having some kind of injury down at that joint, just testing them out in a low stakes environment. So not asking them to load at full competition weights in the relevant position. So getting the ankle into that step back posture and saying, do we get a lot of discomfort here that we're not seeing if we're just standing upright? I think that could be pretty key. Otherwise, looking for very sudden changes, especially if you're tracking a single athlete over a long period of time. If you've got someone for a full season, maybe you can be a little bit more aware of, is there a sudden drop off in strength or a sudden asymmetry that wasn't there the week before? I think that like longitudinal data can be really helpful as well.
Hmm. And I'm glad that you brought up the step back or the false step because I'm not there at the tendon conference, but like I know there's like a conversation about like the false step because
Mhm.
you're never gonna coach the athlete out of that. That's just what they do. So uh does it help us really know like the false step is a injury mechanism or like actually didn't matter?
So I think it is, at the end of the day, it still comes down to no matter how well trained an athlete is, no matter how perfect their tendons are, you can have the perfect storm of a really bad day with a really bad position, or even if they do everything perfectly, someone could trip over and knock into anything can happen. Um, I think what's important about noticing, acknowledging whatever else some of these higher risk positions is that it gives us a good target for, like I was saying, if we want to actually test strength at the highest risk positions, then knowing, this is the most likely posture that you're going to have someone rupture in, being aware that maybe we need to check out, especially in return to sports. So if we have someone who's already had a rupture and they're coming back, if they have tendinopathy and they're trying to go back to full level competition, knowing that those are kind of the worst case scenario positions that we can test them in. And it feels wild to call it worst case because they're going to get in that position just as a matter of moving around on a court or a field. So I think that's really where it's important. It is one of the cases where it's like you said, we're not going to tell people don't ever put your foot out behind you. That would be a little bit counterintuitive to just playing the game. Um, but I think just knowing where we need to be most aware, especially when people are already higher risk, this might not be a concern for 80% of the athletes who, aren't really at risk and they're just worried about that one, really bad day, perfect storm situation. But for the ones where we can actually start looking in a little bit more, zooming in, making sure that they're ready for sport, I think that's really where we need to be aware of what the like max risk positions might be.
All right, so my following question is like there's research talking about like a lot of the Achilles tendon happening, they have like paratendon pain or like plantar
Mm,
fasciitis or like whatsoever.
mm.
Um, so I guess my question is like if it's a degenerative tendon, are we really able to change the structure of the tendon? I know some say like you can't, but some say you can. So what are
Mhm.
your thoughts?
It is not the fastest tissue to change. So if we're thinking, is it as easy to change as a muscle or a bone? No, it's not as easy to change as those. If you have a lot of really sudden swelling, that might be something that could change pretty dynamically. But in terms of just if we're saying I want someone to put on 5% size on their Achilles tendon, it's not necessarily the easiest thing to do. Um, Possibly if we're working with like adolescent and youth athletes and we're thinking about people who are already growing and remodeling really rapidly, that might be where I might consider history of loading and that type of thing to have some effect on the structure. But realistically, the structure of the tendon tissue itself, not super easy to change. If we're looking at something with sudden influx of swelling or perhaps some of the muscle tissue, right, where it's inserting into the tendon, that type of thing, that might be a little bit faster. But I mean, we're looking on the scale of several weeks to get some real structural effects on the tendon, and that's only if you're really focusing on bumping up that tendon. So it's a hard target to hit.
Mm. So I guess what can we actually do to not gonna say prevent because that's impossible, but like at least decrease the chances because
Mhm.
as we all know, like every team sport, like the game demand, the speed of the game is only gonna get faster and faster. Not only with for basketball, it's also for hockey, American football, and they're like either way they're gonna have these like patella tendonitis,
Mhm.
patella tendinopathy, or like Achilles tendinopathy. Like since it's the hardest tissue to change. Like, what can we do?
So I think this is where we can kind of inform on what the ACL biomechanics world's been doing for a couple decades at this point. Similarly, your ACL kind of is, you can modify it slowly with a lot of focus, but your ACL is kind of what it is. However, when we think about other things that are modifiable factors, so neuromuscular control, training people to be just more cognizant of the posture of, say, their ankle for their Achilles tendon. If we know that the biggest injury risk for ACLs is when you land funny with your knee pretty straight, then we train people on how to land better and just get that muscle memory in of many repetitions of a movement that we know is high risk and also high demand. So in that same sense, maybe if we know that, say that, step back position is going to be a pretty high risk position, and we maybe identify that someone has, a history of tendinopathy or they have active pain and that type of thing, maybe that's somewhere where we just get them to do drills or really focused warm-ups or, off time training, where we can just try to get them into the best habits that they can have so that it might not fully offset their non-modifiable factors, but getting them into the habit of putting themselves in the most protected position so that it just becomes kind of that second instinct when they're in a game situation and they're not thinking about it. If they can, get their foot back with a little bit more bend in their knee or something along those lines, try to keep their feet a little closer together to minimize that ankle angle. That might be a direction we could move with it.
Hmm. Um, this is interesting because I've been reaching out to like different tendon expert
Mhm.
to talk about like tendon, and what I realize is like even researchers are talk when you talk about Achilles tendon or patella, they're talking about like uh the joint or
Mhm.
the muscle around that area, not just the pain
Mhm.
side, not just calf or not just knee, but also maybe like the glute or like the range of motion. Why is that? Like, because I know like a lot of medical staff they're gonna be myopic about the injury site, but uh, why are even tendon researchers are looking outside just the tendon itself?
Mhm. Yeah, so I think one of the biggest parts of this, like I guess there are two ways that I would really think about this. So one of them, when you're dealing with telling a patient or an athlete or just a normal person what to do in terms of strengthening or becoming a little bit more cognizant of their movement patterns, that type of thing, it is very hard for me to sit here and tell you, hey, I want you to think about stretching your Achilles tendon, not by moving your foot, just like think about your Achilles tendon until it stretches. Whereas if I tell you, hey, can you, stick your foot behind you so that you kind of get your ankle into a really good dorsiflexion, that's a little bit easier to manage. So I think that's one of the big areas is at the end of the day, what we're trying to get with that is some strain through the Achilles tendon, more mechanical stimulus into some of the tenocytes, that type of thing. But if we're not looking at the tendon while it's sitting in a petri dish on a lab bench, then it's really hard to prescribe people to do things at the tissue level. So I think that's kind of a hallmark of good researchers, clinicians, practitioners, all of the above, is when people are a little bit more aware of what is actually doable for the patient or the target audience. So I think that's one of the really big areas. And then the other area that comes in from more of the biomechanics, biomedical engineering end is thinking about the difference in more passive and active tissues. So if we have a tendon, again, this also comes back to I can't tell you to just think good thoughts at your Achilles and it'll stretch. Um, the tendon is a nearly exactly passive tissue, so it basically just responds to being loaded from the muscle or from postural changes. It does restore and return energy, but that's through like a very elastic mechanism. When we think about tissues that we can get a little bit more direct control over, we're thinking about more of the active tissues, the muscle activity. So whether that's just telling the person, hey, can you, you know, tighten up on your calf muscles or your quads or whatever else, or if we're looking at kind of targeted more like extrinsic factors of saying like, hey, we're going to move you through a knee range of motion or an ankle um, plantar flexion or whatever else. That's really coming down to kind of that difference in the active and passive tissues.
Mm. And like I said, a lot of these guys are going to have like uh what's the word I'm looking for? Pathology changes or
Mhm.
like degenerative tissue. And it's gonna take probably more than a couple of weeks to like really make those tissues adapt. So I would assume like off season would be the best time to like really has some changes. So let's focus on the Achilles tendon first. So what would be your advice for someone that like maybe had some sort of like Achilles tendon pain? Like what type of exercise you would recommend?
Yeah, so I think it would probably depend a lot on the um, length of duration or how severe they are at the onset, that type of thing. There's a big difference in someone who's had kind of an achy tendon, but they're marathon training, and it's happened for the past 200 miles versus someone who's been perfectly fine and then they felt a bad twinge playing pickleball, right? Um, so I think a lot of that comes down to working with probably directing through a physical therapist or that type of thing and really focusing on is this a strength problem and we need to just kind of overall provide gentle rehab, or do we need to go into a very protective mechanism and make sure that if there is some kind of immediate risk or injury risk, that we're not doing anything to exacerbate that. But yeah, I think that's kind of the big direction things would move in and then start teasing it out from there.
And as for exercise, I know like Joe Cook or Ebony Rio, they like to do the four-stage rehab, like isometric, then isotonic, and then energy restore, then return to sport. So let's say at the beginning of the season, would you do like mm, um would I ask it a different way. For isometric on plantar flex position or neutral position and dorsiflex position, thoughts on like these?
So I think a big part of it would come down to like a lot of the rehab work that we're working with here at Delaware focuses on kind of a pain monitored model for doing progressions and rehabilitation. Um, and certainly some people with Achilles tendon injuries are going to have their pain flares up when they're in a dorsiflex position versus a plantar flex or vice versa. Um, I think if someone's only having pain and minor to moderate symptoms in a very dorsiflex position, it makes a lot of sense to focus a lot of that rehab and strengthening really around that painful position. So really trying to target that response and that treatment paradigm towards the actual individual symptoms, because that's Achilles tendon injuries, they can get grouped down into, oh, it's either tendinopathy or tendon rupture, but there's a wide variety within either of those of, is it truly the mid-substance of the tendon? Is it only regions that run up to the soleus muscle or the gastroc muscles? Is it down by the insertion? So I think like really using that kind of pain monitored model and saying there's probably not a one size fits all for everyone. Where is this person actually having problems, and what can we do to strengthen or improve that situation?
Hmm. So, I mean, as a strength coach, I need to ask questions that like could help like us do like what I guess help us to decide what should we do in the weight room. So like in what situation you think like maybe focus on dorsiflexion would be better? What situation neutral would be better? What situation uh plantar flex position would be better?
So I think my main approach with that would probably be looking at sport-specific positions and sport-specific needs. So if it is someone who, a baseball player isn't going to be stepping, well, unless they're, outfielding and trying to catch behind them, they're moving forward a lot more, right? Whereas if you've got a basketball player, someone who's doing a lot of cutting motions and kind of stop start, that type of thing, we might be looking more into people who are getting into that step back role. So in those cases, I would probably say looking at the actual sport or the athlete or position specific demands and actually kind of guiding off of that in terms of what the strengthening might need to focus on.
Hmm. And another thing related to this is like I was actually having a conversation with a rehab specialist for football, and I think as you know, like football actually have a lot more Achilles tendon tear than and a lot more calf strain than basketball. But the
Yep.
timeline is so different. If you have like the same type of injury, like a grade two calf strain, like it's probably only gonna take football players 2 to 3 weeks to return to play. But it's
Mhm.
gonna take like if it's a grade two, at least 6 weeks for basketball. Why do you
Mhm.
think there's a difference between there? And like and like I feel maybe I'm wrong, but I feel like the Achilles tendon tear after a calf strain is actually a lot less in football. Or maybe I'm wrong.
Yeah, so, and I don't know either sports like very specific numbers off the top of my head for either of these, but my best shot at it basically is the actual demands of either sport, both in terms of the player schedules and the actual, what happens when they walk out for game day, right? Those are pretty variable. I would say across the board, there's also more variety in football if we think about kind of what the different player position demands might be. Whereas for basketball, we've got a lot of people moving back and forth kind of along a court at a, maybe not a very consistent speed, but they're moving at a good clip. Um, for a long period of time. Whereas for football, there might be some players who are able to have a little bit less of a distance run situation or that type of thing, or they've got much shorter duration. So they might be able to get recovered enough for the one game a week a little bit more rapidly, as opposed to having demands of multiple games a week and however many minutes of play and that type of thing. So I wonder that might be part of it, especially on the muscle side. Again, I'm not completely sure, but that would be my best shot at it. Um, and then thinking in terms of the, sorry, the differences in terms of how that injury might actually be returning or propagating that type of thing, and how it might not be turning over into an ACL or an Achilles rupture, rather. Again, this almost comes back to if you have a lot of pain in your Achilles tendon or in the calf muscle that's attached to it, you're probably not pushing yourself to that 110% mechanical force that you're really expecting to see a rupture through. So there are absolutely instances where pain is protective and pain is a really good information system for the body. And so that might be part of it is if people are just not going into that a little bit overextended, a little bit too much posture that can actually be protective against a catastrophic failure injury.
Hmm. And all right, what happened if someone really like, let's say someone really tear it? And so, um, can you give me your thoughts on like the rehab process? Maybe how fast should we like start partial weight bearing or at least like seated plantar flexion?
So I think going with the general concept that most of these injuries are going to be surgically repaired, right? In the US and the athletic population that we're talking about, at least. I I mean, I think a lot of it comes down to when is it protective to not have any motion through that ankle. So basically, we're just trying to avoid not only avoid re-rupturing, but avoid tendon lengthening after that surgery can be pretty detrimental. So basically, if you've got that tendon and everything's remodeling, if it gets too stretched out, then you're going to have a really hard time getting the slack out of that rubber band later on, generating enough strength and that type of thing. So I think following a lot of the specific guidance based on whichever surgery was performed, where the injury was, that type of thing, making sure that the actual ankle is kept static or in the appropriate posture is good. I think typically we're getting at least kind of touchdown balance, that type of weighting pretty early on across treatments and injuries and that type of thing. Things that I would really think about is what around that leg you can actually keep strengthening and keep moving through rehab. So making sure, sure you're keeping the ankle really static, but are there options with electrical stimulation or looking at, even thinking about maybe BFR training, that type of thing? So how can we get the muscles keeping kind of their connections active, keeping things moving along without doing anything that's going to risk negative outcomes in terms of the return of the structure of that Achilles tendon?
And outside of that, anything else we need to like uh look into or like be prepared?
Yeah, so I think one major thing that I would just kind of be aware of as players are coming back from a rupture and a repair, is thinking about they're not going to have the best coordination and biomechanical patterns in the world. They're working on a new Achilles tendon that doesn't necessarily have as many sensation pathways basically anymore. They might have a very different range of motion. They might have an ankle that has a huge range of motion and you don't want them getting to the end point of that range, right? So I think just thinking through not only building back muscle strength, so much rehab is focused on regaining symmetry and strength and tissue size. But at the end of the day, if the quality is absolute trash when they're using one limb over the other, that could put them at risk for hurting, they're favoring everything onto their intact limb. Does that put them at risk of further damage? Just because they're all of a sudden doing all of their athletic activity on their probably non-dominant leg, frankly. So I think thinking about that coordination and like movement quality pattern on top of just getting strength symmetry back.
Hmm. All right, enough for Achilles tendon. Let's talk about ACL. Same as Achilles tendon, like it's a season-ending in yeah, it's a season-ending injury. It's probably gonna take and the uh maybe I'm wrong, but if you did I forgot the name, but it's probably gonna take 2 years to get that uh tendon to become a ligament. Am I correct?
So basically, with the ACL, when we're doing the surgical reconstructions on this, you're taking a graft site tendon. So it's usually the patellar tendon or the hamstring tendon. Most of the time, it could be a quad tendon, IT band, could be
Yeah.
a cadaver tendon. But you're taking a graft tendon, you're doing carpentry, putting it back into the knee where the ACL used to be. And then major things that are happening around that knee joint are you're making sure that where it's anchored onto the bone, so it's anchored onto the femur and the tibia through bone tunnels, you want to make sure that it is very secure there. So it's waiting for the bone to really reattach to that graft tendon. Um, and then the tendon itself and kind of the graft is what I would refer to it as in the middle of the knee is being remodeled a little bit to become more organized and just kind of appropriately structured and organized to act as an ACL. Um, Overall, a huge amount of this remodeling happens in the first 6 to 9 months. But certainly out through 18 or maybe even 24 months, you're still getting some structural change. It should be pretty functionally stable after that 6 to 9 month range, but there's a little bit of turnover that just kind of keeps going on as long as you let it, honestly.
Hmm. And uh I'm assuming like we talked about, it's almost impossible to like prevent it. But like mm, are we able to like at least make it stronger somehow?
So we're able to strengthen the knee joint itself. It is very hard to target an ACL, mostly because hopefully your ACL never gets to the point where it's so stretched out that it's actually like learning new things and responding to new mechanical load. The goal is to not let it get that far. Um, when it does get that far, that's when you get ruptures. But I would say the main things that we are able to pull from, and this is definitely work that's um, gotten pretty well populated over the past, I would say 20 years, maybe at this point, 15 or 20. Finding people whose movement patterns put them into really risky positions. So it gets back to we figured out what the knee looks like when it's actively rupturing. If it looks like that, it might be too late for someone, but we can watch people, especially a lot of the screening tests will have people jump down from a box, like do a drop counter movement, jump type of movement, and looking at how much kind of valgus collapse and just kind of what their knee stability looks like when they're landing from those jumping positions. That can really tell us, okay, do they have a really good neuromuscular control and they don't have a lot of collapse? It just overall looks like they're keeping their legs kind of in good lines, maintaining a lot of control, good symmetry across sides, all of that good stuff. Those people were generally a little less worried about than if you have someone drop off a box and their knees knock into each other. Or if you have someone and you're practicing cutting and pivoting maneuvers, and all of a sudden it looks like they're about to topple over whenever they cut hard, that's probably a pretty high risk person. Again, what's nice about that is when we identify people who have less good neuromuscular control in these high risk positions, we can actually train them into trying to give them kind of extrinsic cueing and a lot of feedback to say, hey, we need you to build up the muscle memory of when you are jumping and when you're landing from a jump, importantly, don't let your knees collapse in towards one another. There's all sorts of different cues you can use, intrinsic, extrinsic, whatever. Drive your knees out to the side of the room. You can put a foam block between their knees, whatever it takes, to try and train them into good, stable positions, especially, it's what you would just call like athletic jumping and like an athletic landing, right? So I think again with the ACL, and this comes back to all the tendon people, love tendons and then love to talk about everything but the tendon. Just getting more stability about that knee joint, especially in very dynamic movements, is kind of the key thing that we can do to help uh, when we know someone is flagged for being high risk for ACL.
Nice. And uh when I reached out to you, I was doing a little bit of homework about
Mhm.
your research, and I learned about this. Maybe it's not new, but it's new for me. About there's like different portion of the ACL. There's anterior portion and
Yeah.
the posterior portion. Can you talk a little bit about that? And
Mhm.
I didn't fully understand the concept, but is that gonna affect like the injury risk or like how strong is the ACL?
Yeah, so basically the ACL is made up of two primary bundles, the anterior medial and the posterior lateral. Anterior medial comes further forwards and towards the middle of the knee joint, and posterior lateral is behind and outside of it. Um, it is something that matters a lot to researchers and not a lot if you've torn your whole ACL. So certainly when ACLs are reconstructed after they have been injured, um, 99% of clinicians will just put through a single ACL graft. We're not doing a double bundle reconstruction. That was something that was investigated for a few years, but it's not super popular. Um, so overall, the AM bundle or the anterior bundle of the ACL is in adults the primary mechanical resistance. So that is primarily what's preventing your tibia from moving way too far forward. And that's kind of what the classic like ACL testing, like the Lockman test and all of that is really looking for is do you have that anterior stability? The posterior lateral bundle plays a lot more of a role in rotational stability. So if you've done like a pivot shift exam on someone or seen a pivot shift, having that kind of twisting under the knee, that is more the role of the posterior lateral bundle. Um, the main times this would come up in like a clinical case, if you have someone who has a partial ACL tear. So again, these are not super frequently diagnosed in part because a lot of the time, if you rip part of it, you've ripped the other part before you get to the doctor. Um, but if you've got some cases, we'll find these partial ACL ruptures, and it might be one bundle or the other, or at least focused in one or the other. In that case, you might have patients who are presenting with kind of clear signs indicating ACL rupture under certain mechanisms. So if we're testing that anterior stability and the AM bundle's gone, maybe it looks super ruptured. As soon as we throw into a pivot shift and we're looking at more of that rotational laxity, you're like, oh, this is weird. The ACL is still there. So anywhere where there's a confusing diagnosis or there's like need for follow-on imaging, that type of thing, that might be a case where we're seeing one bundle but not the other rupturing. Um, Again, at the end of the day, generally, if the knee is super unstable, it's going to be treated. And if you're going through to replace it, you're just kind of replacing everything. But that could be an area that comes into play. And there are, especially with children, so especially in youth athletes, and this is where you get a couple of the athletes who like made it to NFL Combine, got a bunch of imaging, realized they have no ACL in their knee or whatever it is. Um, that might be an instance where kids are really good at adapting to things and they also have tissues that are actively growing and kind of replacing themselves in interesting ways. So partial injuries in kids might actually be an area where the patient actually just kind of copes with and responds well around the injury and is able to bounce back from it. Whereas with most adult cases, we don't see a lot of people saying, oh, I have no ACL, but it's fine. So that might be one of the areas is if you're only rupturing the kind of less important bundle, then, that could be an area that pops up.
Hmm. And this is actually pretty cool because I was actually helping one of the return to play athlete in Taiwan, and he actually had like partial ACL tear.
Hmm.
So when it comes to like the because he's in Taiwan, so I don't exactly know
Yeah.
like which part, but like does it matter when it comes to like training or rehabbing?
Yeah. So that's a super interesting case because, and I've dealt with a couple athletes who are in similar boats of, especially if they come in and they've got some instability, but they seem relatively okay. They go in to get looked at, they get some imaging done, and people are like, oh, you've got a 40% tear or a partial tear that's affecting this much of the ACL. Where that conversation really comes down to is, okay, are they unstable to the point that they cannot continue with their sport as it is and they need to be treated? If that's the case, then that's the case, right? Um, if they have some instability instances, so once every 20 minutes in a practice, they're going to have an instance where they have an unstable step or they notice that they don't have good control and they have a partial injury and they've got 2 months left of a major season, or they have, it would be an unfortunate time for them to go out for the 8 to 9 to 12 months that it would take to go through the reconstruction and rehabilitation process. Is it safe and is it appropriate to recommend that they keep playing on that partial injury? Maybe we put them in a brace, maybe we put them through extra neuromuscular training, maybe we just give them a lot of coaching and guidance on, don't get into this one really risky position if you see yourself going for it. That's really where I think those partial injury cases can come into play is when you know that they're unstable enough that they're not happy about it, but they're stable enough that they want to play out the season or they want to play out through the championship or someone's going to the Olympics or whatever else. Um, that's really where it comes into play. And I think a lot of that is where it can actually be helpful to know, okay, did you rupture the part that's controlling your tibial anterior movement? So is that something we need to work on, like straight line starting and stopping really hard with you? Or did you rupture a part that controls a lot of that rotational stability? And do we need to just get you some good neuromuscular training coming down in those positions and making sure that you're not falling into a collapsed knee joint?
Hmm. And since ACL had this anterior medial part and posterior lateral part, does PCL have kind of the same, or it just
The PCL it's less well defined, and all of the bundles, if you want to call them separate bundles, go in pretty similar directions. So it's less of a functionally relevant bundle system for the PCL.
mm. And so when it comes to like returning to play for ACL, if it's a full tear and we did like maybe hamstring graft, quad graft, or like patella tendon graft, I guess. Mm, I mean, different graft, the rehab process would be different, a little bit different at the early phase. But um, mm, I guess from a timeline standpoint, like it used to be, it used to be a year. Then I think a few years ago it was 9 months. And somehow, like if you ask football players, it's gonna be faster, like 6 months,
Oh yeah.
right? And I know in basketball world they're trying to like extend it to like one
Mhm.
year, even more or something. Uh, so
Mhm.
outside timeline, let's talk about function. Like, what are some benchmark you think we should at least like test or like flag to know like, all right, we're good to go here.
Yeah, so well, and the timeline question really comes up everywhere because no one is more confident about how fast their surgeon's timeline can be than an athlete that saw their teammate come back in like a 7 month timeline last year,
I
right?
mean,
Uh,
I literally I had a ACL reconstruction and he's able to go back to play like high level basketball, like D1 level basketball in 4 months. I'm like, that's crazy.
it's so much. Yeah, no, it is the case of that's going to become an entire cruise standard of like, well, he came back in 4 months, so I'm sure that I'll come back in 3.5 because, I'm the best. It's everyone, right? But no, I think the timelines, like you said, like how it progresses in the early stages, especially will be super dependent on the graft site. Especially like if you had a quad tendon graft, then all of a sudden you're also rehabbing your quad tendon, right? If you had a hamstring graft, you're rehabbing your hamstrings. So a lot of that does need to focus in a little bit around what that graft site was. Um, but overall, I think if we get past the everyone's getting their range of motion back, they're getting back to where they can walk unsupported pretty early on. They're getting to where they can progress to jogging at a safe time, right? And then move up to running, all of that good stuff. I think the things that are well outlined in clinical guidance tend to be returning strength. So thinking about knee extensor strength, especially in terms of symmetry, which there's a whole conversation of is symmetry the true goal, but um, I think strength's a big one, getting that range of motion back. And then where possible and when possible, doing the testing actually both in isometric and isotonic manners. So seeing are they strong in an isometric sense at 60 degrees at whatever. And then do they actually move through with force nicely? I think that's really key as well. Something that we've been working on and talking through quite a bit recently is what are the big risk factors that we miss with current return to sport guidance and practice? So thinking about, the kid that performs super well in their return to sport testing, they get cleared, they go back, their first soccer game back, they blow out the same ACL or the other ACL, frankly. So what's going wrong if they had perfect symmetry in their strength and their tendons not overwhelmingly swollen and whatever else? Um, some of the big factors we're starting to think through are performance under fatigue. So, most of the time that second rupture isn't happening in the first minute of gameplay. It's happening when they're 50 minutes in and they did all of their return to sport testing fresh. So thinking about is fatigue something we can either model for or correct for or find quicker tests because no one wants to run a 60-minute return to sport test, especially if they fail it once. Um, so thinking that through and then thinking about the actual muscle activation. So like looking at the quad muscles, doing things like burst testing where you can actually apply electrical stimulation and see how much voluntary isometric contraction can people get versus if you give them a good electrical stim, and just force them to contract? Like, is there a big gap there? Are they not actually able to access all of their muscular control?
Hmm.
So I think those are a couple of the big areas that we're trying to think through. And then something that is a little bit more, you have to know your athlete, know your sport, as opposed to just being general guidance, might come down to like position specific or sport specific demands and thinking through, you know, it might not be as reflected of how much, isometric knee extension strength does someone have. But if you have a volleyball player who's jumping up and down at the net constantly, maybe making sure that their jump landings have good kinematics, like ideally looking at kind of frontal plane and sagittal plane, knee joints during things like jump landings, that type of thing, just to make sure that their very applied functional preparedness is still there.
Hmm. And so we talk about strength and talk about symmetry. Obviously, like everybody everybody tests the knee differently.
Mhm.
So another interesting topic is how fast should we start like doing some sort of plyometric? Because if it's just ACL, I mean, you can technically walk right away,
Yeah.
right? Like, and if it's only ACL, it's pretty easy to get like full range of motion back.
Mhm.
So, yeah, my question to you, like, because are we able, like, this is the right way to ask it. So, if we're gonna like do some sort of like vertical like plyometric, maybe start with like assisted pogo or not even pogo, maybe
Mhm.
just like uh slightly bounce, not even off the ground.
Mhm.
Like, what would be some benchmark you need to check before start doing that?
So I think, well, and this also comes down to is it the most simple possible case of purely an ACL tear, first time ACL tear, they got a really stable patellar tendon graft or something along those lines. Um, I think as opposed to thinking about the timing, the main things that I would think about as early targets are maintaining confidence and being able to move dynamically through something. So even not thinking about putting a body weight on it, if you can get into some position where it's even, using a rag under the foot or a band under the foot and just kind of moving through cyclic motion. So thinking about how quickly can we retrain all of those control patterns of, the biggest risk right after we're reconstructing something is that we're going to dislodge whatever that graft is. Like that's my main concern at least is do we do something that strains too hard and all of a sudden you've, undone the surgery. Um, so thinking about ways that we can move through some of those patterns or even just get some of that activation back before we're putting an entire body weight or a half body weight of load would be a key thing. So thinking about just even passively moving through or having them, actively, maybe not a full heel slide on the ground, but doing something where you could say, hey, just start, moving your knee dynamically through some range, keeping it in a safe range of motion for that time frame. Obviously, maybe not coming all the way out to full extension. Um, I think those could be good areas. And then potentially adding in something like TENS units or some kind of stimulation to get the muscles firing in good patterns. Once that kind of progresses forward a little bit and we're okay with putting half body weight or full body weight on, certainly thinking about moving through just regaining confidence in movement. So I think that's kind of what you're getting to with even if it's not coming off the ground, just kind of being able to cycle through and flush things out. I think a lot of that comes down to just making sure I think having a good gradient of building confidence as opposed to saying you're not ready to do this level of activity until you clear this test. And all of a sudden, why don't you go for a run on the treadmill? Like, that's not the intent of having benchmarks, right? It's saying, okay, here's a whole category you can start accessing, but maybe we need to just gradually build up both the confidence of the actual reconstructed individual and um, rebuild all of the capability and all of the strength and neuromuscular control and that type of thing that they had in the first place.
Hmm. And uh, and uh I want to go back to Achilles tendon
Mm,
because uh well, I was doing some homework. There's like and I read this like there's three subtendon for Achilles tendon.
mm. Yeah.
So if we like backtrack to like before they even tear their Achilles tendon, well,
Mm,
and like if somehow they have a calf strain or like
mm,
patella tendon, sorry, Achilles tendon pain, doesn't matter like which subtendon or like which muscle it strained,
mm.
and would it change like the rehab process?
Yeah. So, um, that's certainly something we're working a lot with right now. So both with tendinopathies and with tendon ruptures, does the location of kind of the genesis of the injury, right? Does that focal point happen in the subtendons? Basically, you've got the Achilles tendon running up to the three muscles of the triceps, surae, soleus, medial gastroc, and lateral gastroc. There's an individual subtendon that runs to each one of those, but they mush together into kind of a super tendon for the Achilles. Um, Generally, it's honestly mostly treated as there's the Achilles tendon and here are the muscles. Right now, a lot of research is pushing forward towards can we actually get better outcomes from either performance enhancing or clinical management outcomes if we are targeting the correct region. So, are we kind of wasting our time training all three of the muscles at the same time as each other if the injury is really related to the medial gastroc? I think what we're seeing with some of that, and hopefully where all of this is kind of going in the next few years, is being able to improve outcomes by actually focusing treatment paradigms and focusing all of our interventions on the relevant parts of the physiology. So, even just thinking about if you've got a straight knee versus a bent knee, you're engaging either the soleus and the gastrocs, or really just the soleus a little bit more, since the gastrocs cross over the knee joint. So if we've got an injury that's down in that or if we've got an injury in the medial gastroc region, we probably don't need to worry as much about the bent knee training because that's kind of knocking down the use of the gastrocs. If we straighten out the knee and we've actually got that good lengthening across all of the joint, then that might be an area where we can really target something with the medial gastroc a little bit better. So almost using that to inform not adding on to and doing more things with clinical treatment, but actually just focusing and maximizing the time that we have for rehabilitation or training and performance preparation.
Mm. And all right, last part of this podcast, I want to talk about testing
Yeah.
because maybe just me, but a lot, like we said, the injury mechanism is Achilles tendon is mm, false step, deep dorsiflexion, or even like excessive excessive pronation.
Yeah.
But when it comes to like testing, a lot of the tests we do is seated plantar flexion or even
Mhm.
standing plantar flexion. Um, I mean that just doesn't make sense to me. So, what are your thoughts on like
Mhm.
if we get a calf strain, if someone get a calf strain, an athlete get a calf strain, like what are the tests we should do these tests and why?
Yeah, so I think a lot of, well, and I'll start with the logic, or some of the logic at least, behind doing the more neutral ankle posture, seated and standing calf raise, that type of thing. It's a very controlled mechanism. It's very easy to replicate and it's easy to track and it's easy to compare across studies, benchmarks, players, teams, years, whatever else. So I think a lot of the value of that is that it is a metric or two, if you count the two different postures, metric of calf strength, right? Um, Certainly, if you are improving or having injury in the Achilles tendon, that will affect those numbers. It just might not be the most dialed in, focused way to look at really that end range of motion or that end range of function. Um, I think if we want to be doing a little bit better of characterizing what is the actual strength capabilities at that risky position, or what are the actual when you're returning from and recovering from one of these injuries, how can we actually build up confidence and tell athletes like, look, you are stronger in your risky area and the risky position. You have improved back up to where you can generate, body weights of force out of that one, coming out of the hole of being too far back or whatever else. So I think that having that combination of it's useful to have really fixed position data. So whether that means we're changing some of these, overall calf strength metrics to have some dorsiflexion, even just putting a wedge under the foot at a fixed angle, that type of thing. There are ways that we can start replicating it in a really controlled manner. Um, we also might want to be thinking about, especially depending on the facilities and the capabilities at wherever things are being measured, it's going to be really tricky to get people to do a force test in kind of that step back position or whatever else. If you're in a position where you've got force plates and motion capture, then absolutely maybe we should be testing dynamic movements and how people actually, go through a cutting motion or whatever else. Um, Short of having that, even just thinking about, like I said, putting a wedge under the foot so that you can get someone into 10 degrees of dorsiflexion, 15 degrees, whatever it is. If you have a dynamometer, putting them into different ankle positions, recording that, even just doing toe in, toe out to try and get different foot positions. I think the more information you have, the better in terms of rehabbing an athlete and seeing where they're coming back to. Um, at the end of the day, having consistent data points that you can collect well is probably more important than having 50 data points on a person. So that's what I would really focus on is, you know, whether if there's a case where someone has a lot of confidence issues in terms of they are afraid that they are going to get hurt making the exact same movement again, maybe that is a movement we need to test them in because maybe we need to prove both to ourselves that they're safe and to them that they do have that control and they are recovering and returning. It's just really a matter of what the equipment and the facilities and that type of thing allow for in terms of do you need to do it in kind of a, mesh together way of let's just put you in different foot positions, but test the strength in a normal, um, strength testing setup, whether that's dynamometer or even just like a Smith machine with a bar, that type of thing. Um, or if you're in a position where you're able to actually have them replicate certain drills and certain training movements, even better.
Hmm. And so another tendon, patella tendon or like quad tendon, if they have like maybe they're coming back from a really bad patella tendinopathy, saying what are some tests we should or like yeah, what are some tests we should do instead of just like force play jump? I
Mhm.
mean, should we is maybe leg extension strength a test that's we should look into or like yeah, what are your thoughts?
Potentially, I think one of the main things I would think about, regardless of which tissue and which joint we're looking at, but with the example of like a bad patellar tendinopathy situation, right? Um, Thinking about if there's a combination of a couple really key tests where we can target what is the actual just straight up strength of the joint. So how much knee extension strength do they have? What is the functional capability of that tissue and joint? So, if they are in a position that relies on a lot of running or a lot of high height jumping, that type of thing, finding a very functional task where we can say, whether it's the advanced version of let's do motion capture and calculate everything, or if it's just let's take video from frontal and sagittal planes and be able to track over time kind of progression in the movement quality. I think having that kind of combination of, ideally getting some pretty pure strength metrics, some functional capability, and then if there's a world where you can get like ultrasound imaging or something to look at the structure, awesome.
Nice, nice, nice. All right, that's all the question I have for you today.
Yep.
So for those who are interested, because I mean, tendon is a big topic right now. There's a ten like probably is that the first tendon conference in the state that translated
Um,
dyssosis? Is that the first one?
so that was the first of this specific conference, but there's some tendon sections of larger different conferences that have happened over the years.
So, for those who are interested in what we're talking about today, where can they find your research or like reach out to you?
Yeah, so my specific lab's research is available through, we've got a lab website out at the University of Delaware. We also publish a lot of papers through, accessible through Google Scholar, that type of thing. And otherwise, we've got, the LinkedIn and the Instagram social media that everyone can follow along with.
Nice, nice.